For those of us that do adult medicine, lysosomal acid lipase deficiency is still an important thing. Granted, it is primarily a pediatric disorder, but we're finding more and more adults who have this disease. And why we didn't pick it up as children, I don't know. But we cannot count on the pediatrician to pick it up in childhood. There are times when the manifestations are just not that dramatic. And so when we see adult patients, and pretty much throughout the age spectrum, I mean, I suppose if they're over 85, we don't need to worry about it, but pretty much not only the young adults, but the middle age and even up into older individuals, let's keep in the back of the mind LAL deficiency. Now, when do we look for it? It's a rare disease. We've got to have something that tells us to think possibility of LAL deficiency. The first and foremost is high cholesterol. And there is this nationwide push to focus on familial hypercholesterolemia. We're doing screening in our adults. We're looking at our adults. We're saying, wait a minute, do you have a really high cholesterol? This is an exciting time in clinical lipidology because we're getting new tools, new drugs all the time, and more coming down the horizon that are going to help us treat elevated LDL. So there's a focus on this, that's fabulous, but remember that everything that looks like standard heterozygous or even homozygous FH is not necessarily that. It could be this rare disorder, LAL deficiency, masquerading as FH. So we see the high LDL, we're going to see a low HDL. Pretty much without exception, that HDL is going to be below the usual cutoff that we would ordinarily see. The third piece is there's something going on in the liver. And the easiest way to pick this up in adults is with elevated transaminases. Now, there are many reasons. You've got viral disease, you've got alcohol use, whatever. But realize that if somebody has an elevated transaminase, we need to think about it, and especially if it's otherwise unexplained, because that is not a part of FH. And so high LDL, low HDL, and then the high transaminases, we need to think this might be LAL deficiency. We've got two choices. We can refer to our friendly neighborhood clinical lipidologist, who should be versed in this and should know exactly how to do the screening, or we can do it ourselves. And the screening is actually very simple. What we do is we get a dried blood spot on a special card, and then we send it off to a laboratory, and there's some laboratories that are specializing in this, and some of these laboratories will do it for free. If we get the right kit from the right people, then we can do this screening in our own office, or if that's a little too cumbersome, fine, we refer for the screening process to our clinical lipidologist. So we either refer for the screening or we do the screen. If they screen positive and there's zero overlap, you've got the normal range and you've got the abnormal range, there is no overlap whatsoever. So this enzymatic assay is completely definitive, completely diagnostic, and it's free to the patient and free to us. So I think we've got an ideal situation if we can just remember that in this haystack of familial hypercholesterolemia, every now and again we're going to run into a needle, and that needle is going to be LAL deficiency. Now, the way we find the needle is it's sticking up at us because it's not only the high cholesterol, it's the low HDL, and it's the high transaminases. And if we've got that index of suspicion, we will screen or we'll refer for screening. If we find somebody with LALD, then we will refer to somebody who specializes in that. And that would be primarily the clinical lipidologist, but of course, the hepatologist could probably help us there too.